I was born at Mercy in Janesville. My dad used to work at GM, but I grew up most of my life in Mineral Point, Wisconsin, which is a small town on the southwest side of the state. Okay. I went to medical school in Chicago and had a really good training experience there. Did most of my clinical work on the south side of Chicago and at Cook County. And then I went to Detroit, and that was a tremendous experience for residency. So I was there from 5 to 10, 2005 to 2010. And as you can imagine, we did a lot of trauma work there in Detroit in the middle of downtown. And we had a really good experience with joint replacement. And that kind of led me to want to do more in joint replacement. So I did a fellowship. So I did another year of training at Indiana University. So there was a really good fellowship at Indiana University. And during a fellowship, you don't have to do a fellowship. And one of the things we're really proud about in our group is every single one of our partners has done additional training to really subspecialize. So we're all orthopedic surgeons. We kind of know everything about everything, but we really kind of are a niche practice. So if you go to a guy in our group, that's kind of I would be considered a regional expert in whatever they're doing. Fellowships are where you'll do research. I wrote 3 book chapters. I did 4 journal articles, and I did about 600 surgeries, most of which were complex hip and knee replacement. So it's not just standard hip and knee replacement. It's when things fail, when things get infected, when things break. And that's been a huge part of my practice throughout. After fellowship, I stayed on as a professor there for 6 years. So I actually taught residents and medical students, and I was the assistant program director for the fellowship. And I married a farm girl from Wisconsin, and she told me in 2018 that she wanted to come home. Her dad was sick, and she said, we got to get back to Wisconsin. So in 2018, we came back, and that's kind of been my story. So osteoarthritis, it is very common, right? And these numbers are actually increasing. The data that I'm presenting to you here is actually from 2017. This is getting closer to about 80 million people in this country now. So it is one of the leading causes of disability, and it absolutely is a huge expenditure to our gross domestic product, to be honest with you, in our medical system. So osteoarthritis, think of this as wear of cartilage, degeneration of a joint. Cartilage is meant to give cushion and support to your joints throughout your life. As we age, we are all going to develop some evidence of osteoarthritis, back, hands, wrists, shoulders, you name it. None of us are free from this. Some of us are a little bit luckier than others. And a lot of this has to do with what you did throughout your life. Injuries, work, other things can really predispose you to these to osteoarthritis. So this is actually a knee arthroscopy image, but I show this because this is a really good image. The left-hand side of the screen, you can see it looks like a nice, smooth, white, pliable surface. The upper side is the kneecap, and the lower side is the thigh bone. And that's actually a probe in between the kneecap and the thigh bone during an arthroscopic surgery where we're examining the knee. And you can see how good that looks. And obviously the right-hand side of the screen is not the same. That is underlying or exposed bone. The cartilage that is overlying is completely frayed. It's degenerative. It's gone. So that's what an osteoarthritic knee looks like. Very similar findings that you find in a hip. So hip arthritis, and I talk about hip and knee, and we're going to talk about hip today because this, I think, hip is a really interesting topic that is changing a lot. What do patients complain about? Usually anterior or groin pain. Sometimes it will radiate to the buttocks. Sometimes it will go right through and radiate to the buttocks. Pain with walking. Sometimes it gets bad where you can't sleep. It hurts at night when you're resting. Progressive limp, and one of the things we see a lot of times with hip osteoarthritis is it doesn't move very well. So getting your foot up to your opposite leg and getting your socks and shoes on and moving this hip around to where you need to, you lose motion because it essentially acts as a mechanical block within the joint. And yeah, I think that kind of, yeah, there we go. Okay, so I'm going to see. Actually, we're going to go back. This is a very degenerative hip, okay? And I did have a previous image, and it just didn't come through on this talk, but this is a degenerative hip. And the arrow is pointing to the kind of the superior weight-bearing portion of that ball within that socket. And you can see that there's essentially no joint space here. And now the bone is changing. Bone is kind of a dumb animal. When it's stressed, just like in a broken bone or a fracture, it proliferates more bone. And that's what's happened here. It's stressed because it doesn't have that same cartilage cushion, so it's creating bone spurs within and around the joint. And one of the reasons we lose motion is those bone spurs start to develop around the joint, and then you can't move your hip, the ball within the socket quite as well. It's almost like a bumper. It's a block, okay? So what are the causes? Genetics. There is some genetic predisposition. There's no genetic markers per se, but there is some genetic predisposition. High impact activities are repetitive stuff. So construction guys that work on their feet all day, laborers, clearly if they're doing a lot of heavy lifting, pushing, pulling, and on their feet on hard surfaces, they're more predisposed to arthritic conditions. Previous surgery. So this is important. If you've had a prior operation, if you had a broken hip, if you had work around your pelvis, if you've had a hip arthroscopy, if you had a previous injury. And then obviously obesity. Obesity we talk about because it's really the only modifiable risk factor that we can do as a patient. We do know that the loads across our joint go up as we're carrying more body mass, right? So if we can diminish our body mass, we can diminish our the symptoms. Okay, so this is a really important slide because one of the things we take great pride in our practice and always have is, I think, the very ethical approach to patient care. All of us have been patients before. And what we want to do is we want to see, can we make you feel better and improve your quality of life without a surgery, right? So that's my first job. If I'm not doing that, I'm not doing my job well. Okay, so I would say the overwhelming majority of patients, if you looked at all comers, we almost always try to exhaust conservative measures, and sometimes that's as far as it goes. We're relatively successful. So a lot of things on this screen has nothing to do with surgery, and that's important, right? One of the things I want to touch on is there is a difference between Tylenol and non-steroidal anti-inflammatory medication, okay? So a completely different mechanism of action. Tylenol or acetaminophen acts centrally through a mechanism that is a good fever reducer and pain reliever. It is not an anti-inflammatory, okay? There's no anti-inflammatory capability that Tylenol has at all, okay? So if you have inflammation from a arthritic joint, or you have inflammation from a contusion that you sustained or a sore muscle or other things, Tylenol can help with the discomfort. It cannot help with the inflammation. So when we talk about anti-inflammatory medications, that's Motrin, Advil, Aleve, Celebrex, naproxen, these classes. Now, these are really, really effective medications, okay? They work through inhibition of a COX-1 and 2 pathway, and there's a direct link with the non-steroidal anti-inflammatory medications with your kidneys, your belly, and there's also potential cardiac risks if you take them long-term. So Tylenol has a 3-gram limit because it's metabolized in your liver. Okay, it used to be 4, now it's 3. They lowered the recommendations. The non-steroidals like ibuprofen, Advil, Aleve, you have to make sure that if you're on them chronically, somebody's at least taken a quick look at your kidney function with a serum study every once in a while, because some of you who have taken them may say, yeah, when I was on it for a long time, it did cause me GI upset. And it could rise your kidney function. So very, very good medications. So I bet everyone in this room has taken these medications just to get through the day, or sometimes you've relied on them. Very common. Exercise and strengthening, very important early in the arthritic process. What you'll note is later in the arthritic process, when it's more severe arthritic changes, oftentimes formal physical therapy or exercise and conditioning can actually exacerbate your symptoms. And that makes sense, right? If your arthritis is severe, you don't do as well when they're pushing you on the treadmill and the elliptical and the leg press and doing a bunch of stuff. You say, yeah, I could barely get through the session. By the time I get home, I had to sit down for an hour. And I hear that commonly with hip arthritis, okay? Injections, very important. We don't do a lot of joint lubricating injections in the hip. We do a little bit more data on the knee side. I will tell you it's not great data on the knee side. but the steroid injection has really been the workhorse for arthritic joints. Hips are different from knees. So knees, I think safely 2 to 3 times a year, if you had to, you could do that every 3 to 4 months, okay? In a hip, you really don't want to get super aggressive with multiple injections in a hip. And the reason why is because there is an increased prevalence of avascular necrosis with hip injections, which means the blood supply to the bone itself can be disturbed and it can lead to advanced collapse. It can actually make the condition worse. I find a hip injection an invaluable tool though, okay? Especially in moderate or less severe forms of arthritis, the hip injection can actually provide really, really good relief for a long period of time. Now, ultimately, it doesn't reverse the disease process, doesn't change anything. You don't go from having bad arthritis to no arthritis after an injection. What you're trying to do is just control symptoms so you stay away from me, right? Weight loss, very important, bracing, activity modification, a lot of things that we can try. I think what has come into vogue recently has been CBD in supplements and gummy bears. It's been very, very popular with sleep aids and pain relief. And frankly, there's actually some pretty good literature on it. And it's safe, it's not habit forming, it can help with sleep, it can help with function. So I think there's more and more data that will come out of this CBD because CBD has kind of taken the country by storm a little bit over the last 3 to 5 years.
What is CBD?
CBD is essentially a hemp form or hemp extract. It's basically the non-THC component of marijuana. So THC is the habit-forming or hallucinogenic or more, I would say what we think of as if you're gonna have marijuana, that would give you the drug side effects of that. The CBD is basically the hemp extract, which, you know, if you look back historically, and I'm talking well before modern medicine, this is what, you know, native folks in this country used for pain relievers, okay? Surgical treatment, we're going to talk about this, and I think it's important. Arthroscopy in a hip, typically in athletes or young adults, they have to have no arthritis. Now, arthroscopy you got to be careful with. If you push the indications for putting a camera into the hip joint, it actually can cause substantial iatrogenic damage. Meaning, if you already have arthritic changes, it will not work. You can't go in there and just spray the joint with some fluid and trim some stuff up and hope for the best. They actually will progress fairly quickly with worse symptoms. So hip replacement, we're going to talk about what's happening with hip replacement. Pretty common procedure. One of the most, I would say, if you look at the CMS data, and this is tracked year in, year out, that's Center for Medicaid and Medicare Services. They track functional outcomes in patient-reported subjective scores on all surgical procedures. The most popular, I would say, subjectively from CMS data, surgery in the country is cataract surgery, okay? So that's number one. And out of every other surgery in every other part of your body, the next is hip replacement. So that should tell you something. That should tell you that this is a very, very durable and good procedure that provides substantial life benefit, right? So if you take somebody who cannot walk, who can't move, who's functionally impaired, limited, and has severe pain, and you give them the ability to walk with no pain and be able to be far more active, hip replacement is a great operation. Now, what's the difference between hip and knee replacement? Because knee replacement is not too far down on the list. The reason why knee replacement isn't further up the list is because hip replacement is an easier rehab, similar to cataract. Hip replacement is an easier recovery. It doesn't have as much pain associated with the procedure. Knee replacements tend to have more pain associated with them. Okay, who benefits? Osteoarthritis, rheumatoid arthritis is more of a autoimmune-based phenomenon. Avascular necrosis is where the blood supply to the ball within the socket is now disrupted and it starts to collapse. Very common in alcoholics and people with blood dyscrasias. Congenital hip dysplasia, more common in females, left-sided hips, firstborn females, breech births. I mean, these can lead to where years ago, we didn't do ultrasound exams in the nursery, right? So if there was a concern about a baby's hips, we used something called the Ortolani and Barlow test. And you had to be pretty good subjectively to figure out, okay, was the baby's hip in the socket? And years ago, we would use Pavlik harnesses, which were those little harnesses that would keep the baby's legs apart, right? We still use those, but now we're better at identifying a dislocated hip, because we know if we don't identify a dislocated hip, by the time they're 45 to 50, they have long-term consequences and issues, which usually leads to premature arthritic changes. And then hip trauma. Okay, so what has changed a lot? Well, the most of the implants in the hip world in the United States are cementless. We don't use cement. So the materials that we have are so good now that they grow very rapidly into the bone. And because they're cementless, we don't rely on a bond like a cement driveway that can crack and fatigue and fail. They grow into your body. So because they grow into your body, the biologic bond becomes so much more aggressive and long-term. So early cemented designs didn't do poor, but if you looked past 15 years, they didn't do great. They did great up to that 15-year mark, and they weren't as good after the 15-year mark. Now we have 25, 30-year outcome data on hip replacements because we've been using cementless.
I have a question.
Yeah.
When you do the hip replacement, do you just replace the ball in the joint, or can you scrape away arthritis?
No, not in the hip. Not in the hip, because that would be arthroscopic surgery. And to be, once you, so you got to think of it like real estate in Malibu. Once the cartilage is gone, it's gone. Okay, it's not coming back. So at that point, you can't put something on the ball, put something in the socket that can give you that cushion back, especially once you start to collapse the joint. At that point, you're not an arthroscopic candidate. You have to be more of a replacement or resurfacing. So if you look at this image, and this is one of the early hip replacement that I did, you can see what, that really, I guess I can't touch it. There's no ball here anymore, right? So this was removed because it was arthritic. A socket was prepared, and this is made of titanium. A stem was inserted in the inside part of the thigh bone. This is titanium. They have a coating on them that literally the bone grows to. So when we first insert them, they're very tight. It's a press fit. Put a screw there just for initial stability, but that screw in the long term does nothing. It's the coating on the socket and the stem that grow into the bone. This new ball is ceramic. What the ceramic is touching is there's a plastic insert inside the socket, okay? And what that is, and that really, if you look at what has changed in orthopedics, highly cross-linked polyethylene, which is the plastic, in the ceramic. So we had problems with metallurgy, because when you're using dissimilar metals like cobalt, chromium on titanium, you can get crevice corrosion where you can actually have metal debris in your joint. Or God forbid, if you used a metal ball on a metal socket, it's a lot of rubbing of metal. In the lab, we couldn't wear them out. We thought we had solved the world's problem. Problem is, what we didn't realize is when they went into patients, and trust me, I did a lot of metal and metal joints, just like a lot of high volume joint guys. We didn't anticipate that the metal debris would cause a severe inflammatory reaction in the patient. Okay, and that was one of the issues with the metal on metal. So ceramic, very durable, is not a metal. It mates with the titanium, so the ball is ceramic. The liner is a fancy plastic. The fancy plastic, if you said what was the one thing from just a component standpoint, it would be the metallurgy and the ability to bond these to your bone, but really the plastic designs. So in the 80s and 90s, we didn't understand how to prepare the plastic to increase the mechanical strength and increase the wear. So the plastics wore out relatively rapidly sometimes within 5 to 7 years, the plastic would wear out. You'd have to change the bearing and go in and do a revision surgery. These new highly cross-linked polyethylenes, European data goes out to 25 years. We're about 19 years right now in the US, which is really good. And we see no wear, no changes at all in that profile, okay? So This is a slide that everybody gets, oh, you're like, you're kidding me. So last year, we looked at our numbers, and I performed a little over 400 joint replacements. And that's been pretty typical for me for about the last 7 years. Almost 70% of the patients went home the same day, all comers. Okay, so that's partial knee, total knee, that's total hip, that's revision surgery. It's actually redoing their joint. So if I took out the revisions, which are obviously sometimes pretty big procedures, that number went up to about 76%. So basically 3 out of 4 people go home, and that number is rising, okay, and rapidly. And the reason why I will tell you it's a lot easier with a hip than it is with a knee, almost no hips stay in the hospital anymore. And I don't care where you go. That is the United States of America right now. Okay, the only reason to stay in a hospital is if you required medical attention, electrolyte abnormalities, nausea, vomiting, something that we would have to monitor you and make sure that you were recovering appropriately, or if you were medically infirm. And I take care of a lot of high-risk patients, and sometimes folks are medically infirm, they don't have support at home, they're wheelchair-bound pre-surgery, and those are the patients that most people don't want to take care of, to be very honest with you, because they're higher risk, they're harder. I love it. Do them all in Rock County, and I have throughout the state. And I think that's how I've made my own name, okay? Those people are the most grateful people you will ever meet, and you take them from a wheelchair setting and you allow them the ability to walk without pain. They're harder for me to manage, right? Because I have to do more resource allocation. We have to go and see them. But those are the people that I really enjoy taking care of. They may stay a day or two, and they may require a place like this in a swing bed unit to stay for a week, right? To help them through that process. But once you get them through that process, they're very grateful. So they're durable, they last. What's new? We're gonna go through this because this is kind of the cool part of the talk. So we talked about the biologic materials. Now, if you look at the metal, the porous metals under histograms and whatnot, they literally look like coral in the sea. The bone grows right into the metal, okay? This is a knee replacement, but this is the backside of a socket on the bottom that kind of shows you how it coats the device, and then it grows in rapidly. This is an actual histogram on the top, and the pink, this is under a slide, so they sectioned a portion of a retrieved acetabular cup. Yes, ma'am.
I don't know what I used to do.
It essentially what it is you're looking at the histology, the cellular makeup of a tissue sample.
Oh.
So histogram here is the black is the metal, the pink is the bone, and you can see what happened on this retrieved cup analysis, how the pink grew right in between the metal interstices, and that's what happens. It becomes bonded that way.
And how long does that take?
It takes about 4 weeks with modern designs, but it doesn't preclude immediate weight bearing.
Oh, wow.
So you're on
You
it
can use it.
right away. You walk within hours of the surgery. Yeah, you're gone from the hospital within hours from the surgery. Okay, so if you came in at 8 o'clock, you may be literally home at 3.
Wow.
Okay, and this is not, I mean, I'm telling you, I did a lot at any university. Prior to me coming to the state, there wasn't as much same-day surgery. We did kind of bring the folks up to speed a little bit from that standpoint, but I can tell you, this is not unique to this area now. This is the U.S. This is the goal, or I would say this is how things are now.
It sounds like you go into the surgery with a lot of pain, but when you're done, you can walk out.
With my patient that we did, I just saw a patient yesterday for his 2-week follow-up, and he told me the same thing. If you have severe arthritis, it's amazing. Sometimes you feel better almost instantly, and usually within 2 to 3 days, you feel drastic difference, okay? bearing surfaces, we talked a little bit about this. Basically, metal on metal, that's kind of a no-no. And we talk a little bit about that. Metal debris, we didn't understand why patients were having problems until we started to take synovial fluid samples and tissue samples from these hips, and we realized that there was metal debris that was causing this super intense inflammatory reaction, and sometimes it mimicked an infection. It mimicked a severe infection. Okay. So this is an interesting photo because these two ugly guys, this is actually a picture of us. Okay. So this was, I think, in the Gazette in maybe 18 or 17, and that's one of my partners, Dr. Ali. And we're standing in front of this weird machine. And at the time, when I left IU, we were doing some robotic-based joint replacements. And at the time, it was not very common. In this state, hardly anyone was doing it. And we knew that that would change. So since 2018, we did a little over 2,000 joint replacements. So they made us stand next to this robot, and that's a Mako platform. There's other robots, but yeah, I wish we had, I asked for an actor or something like maybe Brad Pitt or Matthew McConaughey to step in, but Dr. Ali's a good looking guy, so that's fine. So we're gonna talk about this platform, because one of the things is the first 6 years of the career, milling to prepare a socket, putting in a socket, milling and preparing a stem, you got really good at what you felt and what you thought and how you planned through basically an x-ray that you put up on the wall, right? We templated that way. This has changed the US market. So right now, the American Hip and Knee Society meeting, about 60% of all joint replacements are done robotically now in the United States of America. 5 years ago, that was 15%. In 5 years, that number will be over 90%. So we were just really on the front side of the curve. And we knew that was going to be the case. We knew that. And the reason why is the precision is unmatched. The ability to reproduce what you want for a product is unmatched. So I always felt I was a pretty darn good surgeon, manually. And I realized something, that if I was really honest with myself, I wasn't perfect every time. And it's hard to be perfect. It's hard to be perfect every time, every patient. And what we wanted to do is do that. We wanted to be perfect every time. So the way to do that is, if you have advanced technology and then you train yourself to get really good with it, you can become perfect. And what it does is it gives a very consistent product to the patients every time. So I'll talk about drawbacks and good things and bad things about this, but this is essentially a patient of mine. There's no patient information on here, but this is a patient of mine that here's a CT scan, 3-dimensional model of their hip. We can look at the anatomy. We can size the components perfectly to that patient, and then we can adjust the position of the pieces to exactly where we want them. Okay, that's pretty amazing, right? To say, hey, I want to make sure that my hip looks just like that, and I want to make sure the socket is right there, and I want the stem right there. It's unbelievable how precise this is, and that was not easy under manual technique. Okay.
So if insurance doesn't cover that 3D CT scan, then you would do it manually?
I do. If the insurance won't cover it, there's other options for out-of-pocket cost. Yeah, but this is a screen that we have during the surgery that basically tells me what I'm doing with the leg length on this hip in the comparison to the other side, and the same thing with the offset. How far away is the femur from the pelvis? So that was one thing that was really challenging to assess, right? Really now we can assess it to the millimeter, right? We can say, if you start 5 millimeters short on your arthritic hip, and we need to work on trying to get you 5 millimeters to match you to this leg, now we can do it to the millimeter. Could never do that before, right? So there's just a tremendous amount of information and data. And this is what will happen. That actually, if I wanted that hip there, which is what I wanted, it hit the target every time. So what you'll see here is what it is the robotic arm. I do the surgical dissection. Nothing changes there. We have to prepare the surgical field and make sure that we can actually get to where we need to get to. But in regards to milling, reaming, and preparing, the robotic arm is linked through these arrays to link the computer module. So your CT scan that was done pre-surgery is mated during the surgery by this. We actually put a small little checkpoint in your opposite hip crest. And what it does is, as we map out the bony anatomy, it can find your pelvis on the operating table. So if I move the table, it moves with you. If I elevate or move you around or do anything, so it's really unbelievable, the precision. So this allows me to make sure that I put the pieces in the best spot. So along those lines, we've been looking at another platform as well, and this is Imageless. And this is a really good platform too. So this does not require a preoperative CT scan because we are very, very cognizant about patient cost and how we can minimize cost. And essentially, this is a really, really good platform too, based on intraoperative x-rays, where we can ensure that we're putting the socket in the best position, and it gives us digital reference, which is really accurate. And then it gives us a table so that if we select different sizes of inserts or head balls, it tells us exactly what we're doing with their leg length and offset. So we don't have to sit there and try to draw something out on an x-ray or try to measure things. This is a very good platform too. So we've used both. This one does not require preoperative CT. Okay.
And you get the same.
You do. Yeah, you do. So we're going to talk about this. I'm going to talk about the direct anterior approach. I do both front and back approaches. The direct anterior is a front approach, usually done with a special table. You are on your back. A posterior approach is usually on your side. There's the direct anterior approach, or the modified Smith-Peterson approach, does not detach muscles. We'll talk about that a little bit. Proponents for sure cite less muscle damage. Early functional recovery, I do believe, is actually real, for sure, the first 2 weeks. And then, the indications really depend on the patient factors. So a lot of that comes down to patient size, and then certain things about the patient's anatomy. Certain anatomy of the pelvis and femur preclude this approach safely, and that's important to know. So if you have a very wide pelvis with very short femoral necks, I typically don't do the anterior approach on those folks because their complication risk is higher. My goal is to make sure you have a great outcome, number one, but number two, to do it in such a way that it's safe and we don't have a problem, okay? So posterior versus anterior, and this is kind of where we're at right now in the data. I think this is important. There is zero, and I'm going to repeat this, zero difference on all clinical studies at 6-week assessment and 1-year assessment. None. Zero. At all. Okay? There is a clinical difference early at the 2-week mark. So if you look at the functional assessment scores and you look at the pain scores early, there's a slight increased benefit to the anterior approach over the posterior approach. But I can tell you, having done a little over 1,000 posterior hip replacements, they don't have a lot of discomfort at all anyways, and there's no functional difference at 6 weeks in a year, okay? So I didn't jump on the marketing stuff with this right away because I don't think the marketing, you gotta be safe and careful on how you tell things to patients. So this is the reality. If you ask me, Brian, what do you think? And the data would corroborate this. The posterior approach is safer. It is. If you look at the complication risk, it is safer. Do I think the benefit is that you have the first 2 to 3 weeks? I think that the patients do better earlier. And what I mean by that is, and I'm not pulling your leg, the number of people that walk into the clinic at 2 weeks with an anterior approach that still need an ambulatory aid like a walker or cane are fewer than through the back. That doesn't matter at 6 weeks because nobody needs anything by that point. And I think they require less narcotic equivalents. And that is my experience, and that's what the data says. Okay? But if you're the right patient, we talk about that. Okay? Because I've been doing robotic-based anterior approaches as well, and I think that's a good option for people. So most of the risks like instability or leg length offset discrepancies, these are largely historical because once we developed this robotic platform, now we're able to assess stability so much better that I think the last 3 years, we just looked at a series of about 475 hip replacements that were done. And we had one instability episode, and they were all posterior. So, I mean, it was 1 out of about 500, and that was after a fall. So I don't really worry about instability. That hasn't been something that bothered me. Early in my practice, it's the only thing I thought about. Like literally, like, oh my gosh, what if this patient has a dislocation? What if they dislocate their joint? I don't really even think much about that at all. One of the things is here. The wound, this incision heals more predictably than this incision. And it has to do with how God gave you certain stress points around the actual dermal layer of the anterior part of your thigh. So the incision here is the front approach. The incision here, more on the side, is what we call the posterior approach. There's no deep muscle attachment on a posterior approach. We keep everything intact. The only thing that we do is we split a little portion of the band or the fascia here. That's the only thing that is split. In the anterior approach, we split nothing. Like literally, we just try to manipulate the muscles out of the way and get to the front capsule. The top part on an anterior incision is the part that we always look at very carefully because this is under stress, it's under tension, and this is the one where if we have problems with wound healing, that's where we have problems, right here in the top, okay? Peripheral nerve discomfort, not really a problem in the posterior approach. It can be sometimes because there's a nerve that crosses the field and sometimes that can cause discomfort. And then this is the biggest thing. It's harder to prepare the thigh bone piece. So we have these special tables and we have these special instruments and it allows us to get into this kind of a different position because it's not as clear a shot. If you look at all the literature on anterior approach, if you just search Google and say anterior approach femur or anterior approach thigh bone, this is what they will say. They will say that there's a slightly increased risk of either subsidence, where the stem isn't big enough and it moves down the thigh bone, or there's a break, okay? Now, we've developed things that have made that easier for us to allow us better stability. We've actually developed a whole new line of stems designed just for the anterior approach. Triple wedge taper with a collar. What we're trying to do is make sure that it's a safe approach. And I think we've done, and I've used now a little over 300 of them. I like the stem. It's a good stem. It's really, really a good stem. But that's the truth. So this is what the data says, okay? Early functional recovery without question with an anterior approach. Lower narcotic usage without question. 6-week difference, none. And you have got a couple things that I worry about a little bit more with the anterior approach, top part of the surgical incision and making sure that the femur is done the right way so you don't have a problem intraoperatively, okay? That's it, and that's a lot. I know that's a ton of information, but questions? Yes, ma'am.
Does it take about 2 weeks or less for the bone tissue to start melding, knitting with the titanium?
You will be largely bonded at about four weeks.
4 weeks.
So, yep, but it's doing its work during that 2-week period. You're not changing. Typically, you will use a walker for stability, really more for stability, the first 5 to 7 days. Then you'll transition down to a cane. And then if people are feeling well by 2 weeks, sometimes they don't even bring in the cane. If they need the walker a little bit longer, no problem. Nobody's judging. It is what it is. Sometimes people start and they need a little bit more help. Therapy has largely gone away in some sectors where they don't even do it for hips anymore. It's knees, but not for hips.
Are there exercises that would help?
Yeah, so the most important thing is the pelvis musculature originates off the pelvic rim or brim, and then it comes and attaches onto the top part of the thigh bone. Those are called your abductors. Gluteus minimus, gluteus medius, and gluteus maximus. So we all know about the gluteus maximus because it's that big butt muscle. Well, underneath that butt muscle, there's two really important abductors, the medius and the minimus, that help control and stabilize the hip. So anything out to the side or anything where you're moving out to the side is probably the most effective muscle you can do on hip rehab.
Can you tell, looking at the patient when you first see them, the way they walk, if they have a hip problem?
Yes. So my wife thinks I'm like crazy because we will be at church, at the grocery store, at anywhere, and she'd always ask me this early on. I'd be like, he's got a bad hip, and she'd be like, how do you know that? And I'm like, I do. I just know because I know the difference between a hip gait and a knee gait. And after you see, a couple thousand of them, you know what's going on. Typically with a hip gait, the one thing that you'll notice is getting out of a chair. It'll be this, and then the first few steps, it's like this, and then you'll start taking off, right? It'll start to loosen up. You'll start feeling okay, but you get stiff really quick, right? So when you go on long rides and you sit down for a long time, that's how it is. Yeah. Knees are a little bit different. Yeah, so one of the things, long-term hip arthritis, you develop a hip flexion contracture. So your hip externally rotates and you'll lose length. So because the hip will collapse in the socket, normally it's here and it will do this. So you'll lose length. So long-term, then you'll do this type of thing where you're waddling back and forth because your legs aren't equal.